All right. You should be at Trusted Together, libraries, publishers, and other stakeholders in the future of public health information. And this is the 25th Health Sciences Lively discussion. There are snacks in the back, so please help yourself. And please share your contact information with us via the sign-up sheet. I'm Gwen Evans, librarian and consultant, and I'm standing in for Kim Steinle, Director of Subscription Sales and Services at Health Affairs, who couldn't be here, unfortunately, and I'm delighted to be able to step in and help out as today's moderator. I want to acknowledge that this is the 25th Health Sciences Lively discussion, and thanks to Ramune Kubilius for shepherding this session for over 2 decades here at Charleston. We'd like to have a truly lively, frank, and forthright discussion. So we'd like to follow Chatham House rules, which if you don't know what they are, all participants are free to use and quote the information received, but neither the identity nor the affiliation of the speakers and the audience discussants may be revealed. The session will be recorded, but the Q&A will not be recorded. And also before I introduce the panelists, I'd like to give a special thanks to 2 other session planning members, Montier Dobbins at LSU Health Shreveport and Elaine Hicks, Children's Wisconsin Medical College of Wisconsin, who helped prepare the presentation. Today's panelists provide a wide range of knowledge in the public health space, and we thank them for sharing their expertise with us today. Ramune Kubilius, Collection Development and Special Projects Librarian, Northwestern University Galter Health Sciences Library and Learning Center. Javier Crespo, Associate Director, Public Health Coordination Office of the Network of the National Library of Medicine, and Toby Green, Publisher, Policy Commons, Coherent Digital, LLC. And we'd like to poll the room. How many of you are academic librarians? Most. How many are publishers or vendors? How many are hospital medical librarians? You can be both. Yeah. Other? Anybody else? So, yes, other. So, and before I turn it over to the panelists, please see this slide, thanks to Javier, about the difference between public... Oh, sorry. Oh, and also, sorry, Code of Conduct for the Charleston Library Conference. I'm sure you've seen this before. Please treat everyone with respect and consideration, free of discrimination, harassment, and maintaining ethical and professional conduct. And we will want to use the microphone for Q&A when questioning to make sure this is accessible for all. So this is the what is public health versus what is healthcare. Apparently, this is people are often confused about this. Healthcare industry treats people who are sick on an individual basis. I feel like we are all more aware of what public health does now if you're reading the newspapers, but public health aims to prevent people from getting sick or injured in the first place, entire populations. So healthcare, individual, public health, the body politic, I guess, or body polity. So with no further ado, I'm going to turn it over to the panelists.
So as mentioned, I'm Ramune Kubilius. I can't take credit for every single program over the years, but there have been a lot of topics that we've covered thanks to a whole group of people over the years. So on the right side of that slide are some of the names for the fancy names we've thought up over the years, but we've covered everything from serials, ebooks, clinical tools, hospital mergers, open access, basics, how to serve basic science audiences, how to serve interprofessional audiences. We've had somebody retiring from NCBI speaking to us, a library director from Duke retiring, talking about transformational change. over the recent years, I start right after one Charleston conference, start leading to the next, keeping track of some of the news announcements. And boy, I didn't do very well this year. I walked through the vendor showcase and found out about all these different things that somehow I slipped my attention. But you see the QR code if anyone's interested in looking at my handout, and I have a few paper copies on the table there. We'll be depositing our slide deck as well from this session if anyone's interested. But this year was marked with a lot of milestones and anniversaries. I listed a whole page of different anniversaries. I mean, the 25th here, but then we've got the Royal Society, 300, whatever it is, 60 years. So it runs the gamut. And then a lot of new products, pilots, partnerships, and some things ceased. So that certainly will be coming up in our topic today, which I will get to a little bit. We were hoping that one of our planners would be able to make it. She is both a librarian and has her MPH. I don't have those credentials. But what I did do is I went through my trends handout, and also I've been lurking in a couple of groups just to see what is public health information. Is it silos? Is it islands? Can we be building bridges between the different groups that need this information? So on the top of my slide on the right, I just list in very generic terms that there are a lot of sectors in public health, a lot of disciplines within public health, the same as in health sciences librarianship, that different people do different things. There are different information producers and distributors. And then on the left bubble there, the blue bubble, a lot of associations are in this landscape. So everything from the American College of Public Health to the American Public Health Association, that's going to come up today more than once, that particular society. Also the Association of Schools of Public Health, and also in the Medical Library Association. I've been lurking in that caucus's sessions recently just to kind of get a better picture of what's going on. And they celebrated their 50th anniversary, so they upped their activities a little bit, it seems. And the purple square slide just is a synopsis of a poster they did at the Medical Library Association meeting this year. Through April, they got 82 responses, but certainly there are many more that they could be getting. Among the 215 public health accredited institutions, 64 have schools of public health, and the others have various programs. And then there are the ones that have schools of public health. Our program at Northwestern does not, but it awards an MPH. It's a very small program. So it runs the gamut. But interestingly, of those 82 survey respondents, 10% have their MPH. So they are continuing to work in the field. Some got their MPH first, some the other way around. But I thought it was interesting that 35% have some sort of public health education. So they really feel if they're going to be working in that space, they need to have the subject knowledge. And then their job duties kind of boggle the mind, because many of us in this room focus primarily on collection development or scholarly communications or something kind of limited, but a lot of them are liaisons. They're doing systematic reviews. They're doing instruction and curriculum development and data management and so much more. So they really need our support. The bottom kind of just goes through some of the resources and what's been, my colleagues on the panel will be addressing more, but just even recently, the American Public Health Association, many of us probably saw the announcement, is not going to have an institutional licensing model for their premier journal. Well, two I think they have, but the one that many of our constituents would want and need. So, and I can't believe, I think American Public Health Association has 25,000 members, and Javier can tell me better, but I think there are many, many more public health professionals working out in the field. So depending on who's serving their information needs, they're going to have to get at that journal a different way through an aggregator. And New England Journal of Medicine and a public health group, the Center for Infectious Disease Research and Policy, announced that they're going to try to address what's going on with the government information landscape by addressing and gathering information that Morbidity and Mortality Weekly Report would have addressed. But how and where they'll package it, is it going to cost? That's still kind of, every time I look at that announcement, there's some new information. I think it's going to be in New England Journal of Medicine Evidence, last I heard. In the middle section, more than half a year ago, the government printing office happily announced they came up with Discovery.gov that you can search across all the government agencies for U.S. government information. And National Library of Medicine came up with its data set catalog to kind of try to centralize things. And then the government started playing around with websites and changing names and things, and our colleagues in the government information sector said, hey, wait a minute, and they came up with Government Information Tracker to keep track. Whether that's a snapshot in time or just we can talk about that. And then Toby Green's organization came up with the Policy Commons 2025 Open Collection, and it's a new rescue to open model. So that's kind of interesting, but what I do like it is their attempt in that sector to help with the government information dearth. Duty Corps titles for public health alone, and we know that public health could be health policy, it could be many things, but in public health alone has 35 titles in the 2025 core titles. 3 are from the American Public Health Association, 2 are in National Academies Press, and everything else is university presses and commercial publishers. But when our curriculum librarian at Galter Library asked the program, the public health program, they don't assign any texts at all. So I, as collection development, have to look through these 35 and say which ones should have, even though they're not used in the curriculum. Last but not least is the right column. What are the public health folks, at least those in the caucus, looking towards as they celebrate their 50th anniversary for the next 5 years? And many things they're already doing. So they've already surveyed their membership and beyond. They want to partner with public libraries on disinformation. They want to they have a travel award, so they do send librarians to the American Public Health Association's annual meeting called the Sewell Travel Award. They want to come up with a repository solution for that. They also want to connect with the American Public Health Association leadership. I'm thinking they should have done that quite some time ago, but that's somebody expressed that was an important thing. They want to come up with search hedges. They want to keep up with the Healthy People 23. They're already working on a evidence project for that. They want to learn about public health resources. That's, again, a partnership between collections folks and government folks. How do we identify what it is that people need? And in the academic sector and the people in the hospitals that we're serving are quite different from the ones that Javier will be talking about. And last but not least, I like that somebody observed that public health is for all medical health sciences librarians, so it shouldn't be its own thing alone. We need to partner with our counterparts within the library and without, and we have to kind of see and discuss what is the role of collection folks and scholarly communication folks in this very changing and evolving landscape. So those were my comments. Thank you, and now it's Javier's turn to talk about the other people who do this work.
Hey everyone, thank you for being here. My name is Javier Crespo. I am with the National Public Health Coordination Office, and I'll be telling you about that. Here to talk about the Public Health Digital Library, available to public health departments throughout the country. On the right, you'll see kind of our complement of resources, number of journals and ebooks, but also our cornerstone resources. The digital library is available to public health departments throughout the country for a fee. We are part of the network of the National Library of Medicine. We are charged with expanding access to biomedicine, biomedical information throughout the country. And part of that challenge was taken back to NLM to say, hey, let's provide some resources to public health departments who are under-resourced in terms of evidence-based material. So won't read everything on this timeline, but I do want to say that we started off as a demonstration project offering free resources to public health departments. We reached about 18 departments by 2016 or so, and at that time, the National Library of Medicine decided to create our office to run this program a bit more formally, and it would be a fee-based system. So we're about at 30 state public health departments. 4 of these states support statewide access to local health departments to the public health digital library. And then we have about 10 other local health departments throughout the country. I'm numbering at about 130 or so health departments that have access to the digital library now. We have a component of partner libraries throughout the country that support their corresponding public health department with document delivery support. We go out and find them as soon as we know that there's a public health department that's entering that new state or that part of the country. So some things about our collection. On the right is our top 15 journals, and you'll see that on the next slide as well. I want to talk about our journal migration from one publisher to another. I'm sure it affects everyone. Just 2 examples I have is AORN, Association of Operating Room Nurses. Thank you for nodding. And their e-guidelines. That resource was pulled from the StatRef platform, which we used and offered exclusively by AORN. Costs us 3 times as much to carry that right now. And then Ramune has already mentioned the movement of American Journal of Public Health to be available exclusively through one of EBSCO's packages. So I am anticipating that will cost us dearly if we're going to be able to carry it at all. I just want to mention that we try to collect for all public health domains, not deeply, but broadly. So we try to get some representative titles, whether they're journals or books. We look at use data. We respond to requested titles, and we see what we can do, whether they're going to be sustainable for us to carry, whether they have the availability model that we are able to, that we're going to be able to support, and whether or not that particular publisher wants to work with us. Why do public health departments join the Public Health Digital Library Program, and why do they stay? I'll just point out one case there that indicates that the statewide working group in Washington State asked the state health department, hey, we'd like that digital library too. And so that health department proposed to us offering statewide access across all health departments. So that was a great opportunity for us and a great model to kind of emulate, and we've been able to carry that through in other states. So if anyone is from Washington State, thank you. Okay. So in terms of use cases, I invite you to look at some of the juicy pull quotes below on the lower part of the slide from users. I will say that we have, one of our best uses is actually from New Hampshire, and they're building their policy and regulation around PFAS or forever chemicals. That was an intense time for that department. They used the digital library heavily. They used interlibrary loan heavily as well. And so there are cases like that that we hear from, but also using the resources to support their practice, to support their report writing, whether it's grants or other types of policy documents. And this is my last slide. We are all in times of uncertainty. Our departments commit on an annual basis for their participation, and it's always holding my breath for about 3 months to see if these departments will renew. They usually do. The future is even more uncertain, given things since the start of January. What we know and what we sense and what we hear is that the resources are stable to them, that there are other resources across free websites that may change, that may alter their slant, and we know that the evidence-based resources we offer are evidence-based. They are useful and they are applied. So I talk about uncertainty, but I think there's a lot of comfort we take in knowing that the departments ask us for training. We have on our staff a trainer, instructor, librarian. And so we take comfort in knowing that the departments demand of us instruction, and they demand help with the resources, and they suggest resources for the future. Okay. So those of you who know NNLM, it is a five-year, we call it a contract, 5-year collaborative agreement, 5-year grant. We are at the end of that. We know that the new 5 years is delayed 12 months, so we're on a 24-month year 5 option, and that last year is not funded. We plan to work through this. The departments support us, and right now that's all that I have to say. So I look forward to questions later, and I'm going to invite Toby. Thank you.
Okay, thanks Javier. Hi, I'm Toby Green from Coherent Digital. You might think I'm representing publishers. I'm not really. I have been a publisher my entire career. First half of my career was with mainstream publishers. In fact, they're all owned by Elsevier now. But I abandoned Elsevier 25 years ago, and I went to the OECD. And now I'm one of the co-founders of Coherent Digital. But I'm really here to talk about the other stakeholders, as you'll see. Now, public health is all about helping people not get sick. So I'd like to talk a bit about systematic reviews and how we're helping people who have to do systematic reviews from not get sick from actually doing systematic reviews, because they have a a pain point because doing systematic reviews is a bit of a headache. Now, I guess you're all familiar with systematic reviews. There is this thing called PRISMA, which is how you do a systematic review. If you're not familiar with that, it comes in two halves. There's the half on the left, which is all about pulling out information from mainstream publishers and organized databases. That's totally zen. It's very easy. Everyone knows what they're doing. Everything's nicely organized. And then there's the stuff on the right, which is, as it says, identification of studies via other methods. And what this really means is all the really hard, messy stuff. And this is when the headache kicks in. And this is what we're trying to help. So what's triggering the headache? Well, basically gray stuff. Okay, so the pain's in the gray stuff. Well, it's the gray stuff. So it's all the gray literature, it's gray data, it's gray information, because this is all the content that is not being captured by the mainstream publishers and all the mainstream aggregators, and who make their content all neat and tidy. So we're talking here about working papers, newsletters, tweets, blogs, all sorts of stuff. And then to make the headache even worse, even if you find this stuff, you can't manage it because this stuff doesn't come with DOIs, it doesn't come with neat and tidy metadata, it doesn't fit into your reference management systems, so there are no workflows for this stuff, and it's really hard to try and screw it into things like Zotero and all the other tools that people use. So really, really big headache. So if only all the stuff on the right could be moved to the left, wouldn't that be cool? Because then the headache would go away. The trouble is, there is an awful lot of stuff on the right. Okay, so you've got stuff from logos that you'll know, like the CDC, but there'll be a lot of logos there you've never seen before, really small organizations that are producing content in public health. How do you get the stuff across? And it's enough to drive you to drink. And I'm going to now move on to a little story involving drink, which involves a bar in Boston, but sadly it wasn't this bar. So I was at a conference in Boston, and I'd just flown in from Europe, and I was in some dreadful hotel. It seemed to be in a car park in some back street of Boston. And I went down to the bar, and there were these two blokes at the bar, and they were having a conversation. And this was 2009, so it was when the Obamacare was in the news. Okay, and these two guys were clearly from different sides of the political aisle, and they were sort of being careful not to irritate each other, and they were having this sort of, they were beginning to get a little bit agitated, and I arrive and I order a beer and they hear my accent, and so they start arguing with each other, and then they turned on me. Well, not to argue, but to say, didn't I wish I was an American because the healthcare system was so much better? And I thought, well, that's sort of interesting, because it just so happened that I knew about this report. Now, I knew about this report because, of course, I published it. Now, I didn't tell them I published it. I just said I happen to know about this report. It's got all this wonderful data in it that compares health systems from across the world. And wouldn't it be cool if they could actually take a look at this graph? Okay, so I got this graph out. And this graph shows you basically the fundamentals of health, which is how long are you going to live? Okay, because that's really what it's all about. And how much does your country spend on getting you there? Okay, so basically more spending is bottom on the right. So basically you want to be in the top left. Okay, so you live long, it doesn't cost your society a lot of money. So you want to be in the top left. So you really want to move to Korea, or you want to move to Spain, or you want to move to Italy, because that's really where you live long and the government isn't going bankrupt paying for all the health. Okay? So that's Europe, Western Europe up there, Eastern Europe down there. Where's America? Anyone like to guess where America is? Yep, there you are. So I showed them this thing, and they were a little surprised, as you might imagine. And it was sort of, I'm now sort of reflecting now, what would they feel about healthcare now? Okay, so where would you go to find data about how people feel about the healthcare systems now? Well, you're not going to go to Elsevier or anyone like that. You're going to go to a market research company like Ipsos. They actually have run this program for 18 years now. They've been running this program where they actually go out and poll people on what they think about the healthcare systems. And this is from their latest report, and it found that 53% of Americans think the healthcare system is overstretched, and about a quarter saying that it's really hard to make an appointment because there aren't enough doctors. So this leads on to the question, well, why aren't there enough doctors? So where would you go and find that information? Well, I highly recommend people listen to this podcast. This is an outstanding podcast, and it tells you why there's a shortage of doctors in America. Now, anyone know why there's a shortage of doctors in America? Where's the root of this problem? Anyone know? Well, you have to go back to this report that was published in 1910. This report is still impacting medical training today in the United States. Okay, it set the ground rules for the whole medical education system, and that report is, and that's what I call impact. I mean, over 100 years worth of impact on public policy. That's one hell of an impactful report. But that report, again, it's a bit of grey literature. It's called the Flexner report. And again, you really want to look at that. Now, so who's paying attention to the fact that people are worrying about the shortage of doctors? Well, actually, yeah, there is hospitals, public hospitals in America are now obliged by the Obamacare Act to do what are called community health needs assessments. And they have to do them every 3 years by law. So where do you find them? If you want to know what the health needs assessments in Charleston are, where would you go? Well, you have to go to the hospital websites, and these are the reports for Charleston. And they're available on those websites. So imagine that you're trying to assemble all this knowledge together in one place, okay? So you've got this, you've got the OC going all the way around to these guys arguing in a bar. How would you actually get all this content together? And this is what I'm now doing at Coherent. We're wrapping our arms around all this kind of content. We're tracking it down, we're finding it, we're bringing it in to a single database, and we're doing it at N scale. So we're doing it at a very, very large scale. So we've got 30 million records in our database now. And it includes podcasts, and it includes blogs, and it includes community health needs assessments, and it includes classic reports like the Flexner report. Okay, so it's all now being brought together so that we can then pull it together to the left-hand side of that chart so that it's all neat and tidy, and people can only go to one place to be able to look for the information, and then maybe they won't have a headache. Thank you.